let's take a few minutes to look at anxiety and disorders. We know anxiety disorders are the most commonly occurring class of mental disorders that we see. Within these anxiety disorders, specific phobias are the most common, with social phobia occurring after specific phobias. The least common of the anxiety disorders are the obsessive compulsive disorder and the agoraphobia, without a history of panic disorder. You know, the development of anxiety disorders depends on several variables that affect the way that the body responds to fear and anxiety, such as gender, age, culture, environment, qualities of the stressors, and genetics. In general, anxiety disorders typically begin much earlier than other mental disorders, and women are at higher risk than men. The onset of tic disorders and specific phobias tends to begin in childhood, with social phobias and OCD beginning in adolescent or early adulthood. Post-traumatic stress disorder is associated with a trauma exposure, so that can occur at any point in life. Panic disorder, generalized anxiety disorder, and agoraphobia are the only anxiety disorders that have an adult onset. So let's look at the patho. And I'm not really asking you to memorize that hypothalamus pituitary adrenal gland complex, but I want you to remember some significant things. That anxiety is an unhealthy, exaggerated fear response that often occurs in the absence of a true environmental threat. Where fear can be quite a normal response to a situation, and it can also be life preserving. Anxiety is not so much. It's that unhealthy, exaggerated fear response. However, unfortunately, the body doesn't differentiate between anxiety and fear, so it's going to respond through a fear complex, which is very complicated process, and it involves multiple organ systems. So that's why you see so much sequela in the physical and psychological consequences of people that have anxiety. We do know that persons with anxiety have abnormalities in the HPA, that hypothalamus pituitary adrenal gland complex. There's also a strong familial link. We know also environmental factors contribute significantly. I want you to review the neurotransmitters that are implicated in the pathogenesis of anxiety disorders. Those are listed and spoken to on page 1350. And I think that helps you understand, our treatment regimes with medications. And then I found it really interesting, the research that's going on right now with the glutamate, specifically the N-methyl D-aspartate, and its role in anxiety. Just briefly look at that so that you'll be familiar with that as you read through literature. So how do people present? Well, they very often present most of the time through primary care clinics or through the emergency department with just these excessive complaints of worry, anxiety, and fear. And together with those are physical complaints. And you'll frequently see fatigue, irritability, cognitive changes, sleep disturbance. I also want you to recognize and remember that often these patients have multiple comorbidities, psychiatric comorbidities that often include depression and substance abuse disorder, or substance use disorder, excuse me. So the diagnostics of anxiety disorders, really, the symptoms must meet the criteria of DSM-5, with symptoms being at a moderate to severe level that can impact hygiene, relationships, employment, or education, one or all of them. Generally, all of them is what you're going to see. The patient with anxiety needs a complete physical exam to rule out physical causes. Review of systems is so important. Routine blood work, I want you to review that. You want to make sure you don't miss physical cause, and you certainly want to make sure you don't miss like hyperthyroidism. So you see that TSH is included in that. And then you want to look at toxicology screening in the urine. So differential diagnoses with anxiety disorders have got to include a medication side effect. So that review of systems is just so important, and history. And there's other organic conditions that mimic symptoms of anxiety. Look at those on page 1351, from cardiac, respiratory, endocrine, neurological, medications and substances, to other mental health diagnoses. It is the appropriate role of a primary care provider, such as a nurse practitioner, to manage and treat anxiety disorders. However, patients that don't respond to first-line medication regimes should be referred to a mental health specialist. I also think that they need interdisciplinary treatment with therapy, group, and psychology, maybe even social intervention. So it's like any patient. They really do benefit from multiple disciplines being involved in the management and treatment. The book does a really nice job on the pharmacotherapy, because that, along with cognitive behavioral therapy and psychotherapy, is known to be the best treatment. So look over those in detail on page 1352 to 1353. And look in that list. We've got antidepressants, benzodiazepines, you've got Buspar there, atypical antipsychotics, and psychotherapy. And again, we know management and treatment is the best responses to dual cognitive behavioral with medication. So let's just look briefly at lifespan consideration. Interesting that mood and anxiety in later life tend to decline with age, but they're still common, more common in women than men, like I had told you previously. 7% of elderly people meet the criteria for anxiety disorder as they age. They are very unlikely to develop new onset disorder. Anxiety disorders in elderly are frequently associated with comorbid cognitive decline and dementia, and it's very difficult to diagnose anxiety when cognitive decline is present. Anxiety is one of the most common mental health diagnoses in children and adults. It's often identified by a primary care provider, and we see these children, adolescents, adults avoiding age-appropriate tasks, and lots of physical complaints that can't be substantiated by the PE, by the physical exam. So just keep that in consideration. Education, health promotion. We have to educate family to support and validate patients that have experienced trauma. Trauma-based cognitive behavioral therapy is the most effective therapy used for children and adolescents, but again, cognitive behavioral therapy, along with medications, has been found to be the most effective, more so than just cognitive behavioral therapy by itself. Behavioral therapy for specific phobias or obsessive compulsive disorder is effective. And then I listed some of the three top resources that we've got to be able to give our patients. We also have to focus in on, we can buffer people's stress by really educating about a healthy lifestyle and keeping your body healthy, good nutrition, physical exercise, appropriate and restorative sleep, and then stress management techniques. And then I just can't reiterate how important that initial encounter is as a provider. If someone discloses trauma and the resulting anxiety, that you validate what they're saying, you support them in it, and that you offer the appropriate resources. That initial visit and assessment can mean the difference between a patient reaching improved health and mental health versus not. So that's our responsibility. Thank you.